Okay, and let's go ahead and get started with some updates. So we've had a pretty exciting month of October, but first, I'm not sure if everybody knows this, but today is a national holiday called Giving Tuesday. And so what that is a day where businesses and people donate to nonprofits. So what better way to kick off our meeting than talking about our Winter Wishes fundraiser for the OB Motivate Clinic? And I do have the link that I'm going to send in the chat. And if you are, sorry, having some technical difficulties on my end for some reason, but I will send that in a moment. But if you are interested in receiving the thank you, Dr. Martin, the flyer PDF or JPEG, please send me an email and I will go ahead and send that to you. Okay. And so the Ivy Lab made an appearance at 3 different conferences in the month of October. So first, Brenna presented her research at the ACOG district meeting. Congrats, Brenna. And we had our summer students present at VASAM this past month. We have some of our Castle students, some of our Sword students, some of our registry students. And here are some individual pictures of our students with their posters. And on top of all of that, one of our lab members, Gus, he won the Sherman Master Memorial Scholarship Award on his dissertation data at VASAM.
Oh my God, wow.
Congratulations, Gus, and congratulations to all of our other students. And Dr. Martin presented at Amarza. I don't know if I'm saying that right. Oh, and another exciting announcement, Michelle had her first author publication in September on SORT data, and it has already been viewed over 500 times and had over 130 downloads. So congratulations, Michelle. Oops. Okay, and so we currently have 5 papers in review. AB has a paper in review. Brenna has a paper in review on the data that she presented at ACOG. Shivanya has a paper in review, Gus, and Dr. Martin. And we have 4 recently accepted manuscripts. 3 were Dr. Martin's and 1 was Annabeth's. Okay. And here's some shameless social media promotion. If you are interested in giving us a follow on Twitter, our handle is IvyLab9. And if you just really enjoy our lab meetings and just want to see more, we record our lab meetings and upload them to our YouTube channel. And I believe our handle is the same, IvyLab9. And if you have any difficulty finding it, you can always just send me an email and I'll send you our profiles. And now let's go ahead and move on to our active studies. So first we have Project Better, which provides a theoretically grounded assessment of feasibility and acceptability of a new technology-based education intervention for pregnant and parenting people receiving medication for opioid use disorder. And so if you missed the update, recruitment has been completed. We had a total of 37 participants, and follow-ups are still ongoing. And Annabeth leads this project. And next we have Project SORT, which is what Michelle's paper was on. So recruitment has been completed for SORT. We still have chart reviews that are ongoing. There is a total of 211 participants. And this study investigates the relationship between sleep and opioid use disorder recovery. And Michelle leads this project. Next, we have the registry study at OB Motivate. And this study recruitment is ongoing. We currently have 133 participants enrolled, and this project just tracks the ongoing record of clinical outcomes of our pregnant and postpartum patients who are seeking addiction treatment with OB Motivate. And this project is co-led by AB and I. And the next study we're going to talk about is the postpartum recovery study. And this is a prospective cohort study that included 26 participants. And the follow-up visits have been completed for this. All chart reviews have been completed, just so exciting. And this study compares biopsychosocial factors such as pain, mood, impulsivity, and maternal infant attachment captured during the 3rd trimester of pregnancy and within 6 weeks postpartum between women with opioid use disorder. And this project is led by Annabeth. And then the last study we're going to talk about today is Project Castle. And this project is still in the early stages of construction. We are currently building the intervention for this in SciAS. So this is a computerized intervention that educates medical professionals and pre-medical professionals on substance use disorder stigma. And I lead this project. And our next lab meeting will be in the new year. We don't have a date picked out yet, but as soon as we do, we will let you all know. And we will have opportunities for research teaching presentations in 2024. So if anybody is interested in getting some teaching experience and presenting on their research, please send me an email and let me know.
Awesome. Thank you, Lilia. That was great to end the calendar year with so many fun updates. It was great to have so many conferences, and I love the photos. So as people know from me haggling them to get photos whenever they're presenting. So now we're going to move into our research presentation. It looks like Taylor is here. So Taylor and David are here, and they're going to be they led a project this summer that is really exciting using some of our existing data that we have on women with opioid use disorder here at VCU. So I'm going to let you guys take it away, but before you start, if you can just introduce yourselves, who you are, where you are, and and tell us a little bit about how you landed in the lab. I think that's good for other students to hear.
Yes, okay, sounds good. Thank you. I'm Taylor Hallet. I'm an M2 student, working my way towards our clinical rotations that start here coming up in March. I got kind of involved with the lab through the Summers Dean research proposal situation. So I found Dr. Martin online, and I was able to meet with her and Lilia, and it was just like, I loved him right away, and it was perfect. So I worked throughout the summer doing a lot of the chart reviews, and then doing the summer class as well, which was really great. And then working on this project with David.
All right. Hey, everyone. I'm David. I'm an M1. I'm in the MD PhD program in the health policy stream, and I landed in Dr. Martin's lab through my summer rotations. So I did a 6-week rotation part-time, and I worked with Taylor on the study.
I can share my screen now. Do you know if I'm a co-host?
You should be able to. Is it working?
Okay, great. Let's see.
And those were exactly the introductions I wanted, so thank you. Perfect.
Okay, can everyone see that?
Oh, yes.
Okay, great. Okay. So David and I looked at the association of the receipt of opioid prescription at birth, hospitalization, discharge with postpartum buprenorphine continuation among patients with opioid use disorder. Quite the mouthful.
It
Okay,
is
so just
still it is
yeah,
still
go ahead.
loading. It was there, but I
Oh,
think now it's just thinking.
oh,
The
it says it's
slide.
paused. I wonder why. Let me stop it and try again. Let's see. Okay, you can see that, right?
Yeah.
Okay, I think it was when I put it into slideshow mode. So you try again. It's still, yeah, it goes away. So we might have to do it in non-slideshow mode. Because then when I do that, it says it's paused.
I wish I knew the
Ooh,
answer.
I wish I knew the answer.
Have an
Let's
idea.
try. Oh yeah, let's hear it.
What if you download it onto your computer and then present it from PowerPoint?
Ooh, I think we can make that happen. So just give me a moment.
No problem.
Step one.
So far, so good.
Okay. All right. How do we look now?
Now you're in presenter mode. So I think you just need to
Oh,
reshare it after you start the slideshow.
okay. Got it. And share. Let's try this. How about now?
Yes. There you
Yay.
go. Hey, it happens to all of us, Taylor. It happens
Great.
to us. No worries.
Thank you all for your help and your patience. Okay, so going into a little bit of background. So the postpartum period, as we know, is one of the most vulnerable times for a patient with opioid use disorder to overdose, and it's becoming one of the leading maternal causes of death in the United States in recent years. The current standard of care for those with opioid use disorder treatment during pregnancy includes medication for opioid use disorder, including buprenorphine and methadone. But postpartum discontinuation rates of those medications have been found to be as high as 66%, leading to negative consequences in the postpartum period. Additionally, limited research has been dedicated to the high-risk postpartum time period, and then representing a gap in literature for OUD treatment for this population. There's also a current debate going in the literature regarding the standard of care for prescribing opioids post-delivery to patients with opioid use disorder, where some studies have found that prescribing opioids upon discharge from the hospital increases your risk of OUD recurrence, and others have shown that poorly controlling a patient's pain actually increases the risk of OUD recurrence. And this debate has led to clinicians being unsure how to prescribe or not prescribe opioids to their patients with opioid use disorder in that postpartum period. Additionally, the majority of studies conclude by 3 to 6 months postpartum or exclude those with an OUD diagnosis. But in our lab, we look through 12 months postpartum, taking the entire year as the time frame. So some of the existing research that does exist right now have found some social and structural factors that have been found to be associated with decreased adherence to medications in the postpartum period. These factors include things like homelessness, incarceration, unemployment, lack of insurance, and non-white race and ethnicity. And on the other hand, starting opioid use disorder treatment earlier in pregnancy has been associated with an increased adherence postpartum. throughout a variety of different studies. Additionally, there was a recent cohort study that compared inpatient opioid consumption among different patients, different groups of patients, both those with OUD and those without. And the overall result of that study found that patients with an opioid use disorder consumed greater quantities of opioids after receiving a C-section inpatient, but then received fewer opioid prescriptions at discharge from the hospital following their delivery. However, the impact of this trend on postpartum care and medication continuation and how that impacted that period has not yet been examined. And that leads us to our study objective, and that was to assess the association of opioid prescription receipt at discharge from birth hospitalization with postpartum buprenorphine continuation rates in birthing people receiving opioid use disorder treatment.
All right, thank you so much, Taylor. So for the methods of this paper, we conducted a secondary analysis of a retrospective cohort study. So these patients were followed through January 2017 and March 2022, and we looked back at their data to assess the relationship between receiving buprenorphine and their OUD status. So inclusion criteria: patients were pregnant when entering the parent study and had data for at least 2 consecutive intervals. So if they were missing data for 2 consecutive intervals, they were not included. And they had continued buprenorphine through infant delivery and at least 1 week postpartum, so that we knew they were in the postpartum period. The exposure variable was receipt of opioid prescription upon discharge from birth hospitalization. So this was defined as a dichotomous variable. So it was just simple yes or no. Did you receive opioids during your delivery or not? And the outcome was the week of buprenorphine discontinuation through 52 weeks postpartum. So one thing to note about the outcome is we did a survival analysis. So what that means is your dependent variable, your Y variable, is time to event. So in this case, we're seeing at the period of birth, 100% of people were on buprenorphine, and throughout time, people gradually began discontinuing use of buprenorphine. And we were comparing essentially, do people who received opioids at birth, is that decline in buprenorphine use faster or slower than in people who did not receive opioids at birthing? All right, next slide, please. So the analytic approach. So we just did a very simple chi-square and students t-test, 2 tests for various demographic, clinical, and psychosocial variables. We included a table which will be presented at a later slide. So for the categorical variables, we did the chi-square analysis, and for the continuous variables, we did the t-test to look for significant differences. And then we conducted 2 different approaches to look at our survival analysis. So the first approach was a graphical approach. So we did a Kaplan-Meier survival curve. So how that works is essentially every time someone discontinues buprenorphine, the curve sort of like moves down a gradient and it just keeps moving down. So we're getting we ensure that the curve represents like the follow-up for every individual patient. So as soon as someone's no longer follow up, they stop using buprenorphine or they're lost to follow-up, the curve can reflect that. So the Kaplan-Meier curve is essentially a visual way of representing this, and the Cox proportion hazards model is a regression analysis. So this is a way of quantifying that association. So we want to see not only do we see a difference visually, but can we also see a statistically significant difference through our regression analysis. And we chose a few covariates based on the existing literature. So incarceration status at delivery, psychiatric comorbidity at delivery. Hannah published a great study, which we definitely referenced a lot throughout our paper. So she found that psychiatric comorbidity at delivery was associated with actually greater buprenorphine continuation rates or slower buprenorphine discontinuation, which is also what we found. So we included that as a covariate. We also included comorbid chronic pain at delivery, since essentially our study, at the basis of it is how to find better pain management strategies for patients in the postpartum period, patients who are on buprenorphine who are birthing. So we thought it was important to include chronic pain at delivery, and the number of weeks receiving buprenorphine before delivery was also used as a covariate. So here's just a quick overview of table 1. I won't go through everything, but we included general sociodemographic variables like age, gender, race, education, and more. We also included the types of psychiatric comorbidity, so ADHD, anxiety, bipolar, depression, schizophrenia. Since a significant portion of the sample did have psychiatric comorbidities, we thought it was important to just give a broad overview of our sample, as well as other types of substance use disorders, since a lot of our patients didn't just have a single, they didn't just have opioid use disorder, they had many other comorbid conditions. So we thought that was important to include. And yeah. So for the Prisma flow diagram, we had 233 patients in the parent study. And after narrowing it down to patients who were pregnant upon entering the study, there were 228 patients with at least 2 consecutive intervals of data, 192. And we finally ended with 142 patients who had continued buprenorphine through the delivery process and entered the postpartum period. So here is our Kaplan-Meier curve. The patients who did receive an opioid at delivery is represented in red. And you can see that this curve is lower. So what this means is the y-axis represents buprenorphine continuation. So as your line decreases, this is less and less people continuing buprenorphine. So what we observed visually is that patients who were prescribed opioids at delivery, they ended up discontinuing buprenorphine at a faster pace than people who were not prescribed opioids at delivery. And we also wanted to quantify the differences between these curves. So we conducted a Wilcoxon test to see if these curves were statistically significant. And we got a p-value of 0.03, which was below our alpha of 0.05. So we concluded that there was a significant difference between the curves. And here is our Cox regression model. So we conducted both an unadjusted regression and an adjusted regression. So in our unadjusted regression, we found that being prescribed an opioid at delivery was associated with a 40% hazard, 40% higher hazard of discontinuing buprenorphine. So if you receive an opioid at delivery, you have a greater hazard of discontinuing, discontinuing buprenorphine, not discontinuing opioids. But this difference, this estimate was non-significant because the confidence interval of 0.88 to 2.24 crosses the null value of 1. So it's a non-significant finding. Moving on to our adjusted hazards ratio. As mentioned before, we included incarceration at time of delivery, weeks of buprenorphine before delivery, psychiatric comorbidity, chronic pain as covariates. And the only significant finding that we found was with the psychiatric comorbidity, which was 0.51. And since the upper limit of 0.80 doesn't cross 1, we know that this is a significant finding. So how we interpret this is that among patients with a psychiatric comorbidity, they have a 49% lower hazard of discontinuing buprenorphine after adjusting for the other factors. So after adjusting for chronic pain, incarceration status, receiving buprenorphine, weeks of receiving buprenorphine, and opioid prescription status. All right. And I think, yes, that's our.
Oh, thank you so much, David. That was perfect. So this overall leads us to our conclusion that firstly, receipt of opioid prescription discharge from birth hospitalization was associated with discontinuing buprenorphine earlier in the postpartum period compared to not receiving an opioid prescription at discharge. And to put that in different terms, if the patient was prescribed an opioid prescription at discharge, they would they would end their buprenorphine earlier than those who were not prescribed an opioid at discharge. However, once we adjusted for all the covariates that were previously listed, the only one that remains significant is psychiatric comorbidity. So these results suggest that prescription opioids may be associated with buprenorphine discontinuation in that high-risk postpartum period, but it's very important to consider all the other factors that may be influencing this relationship. Therefore, pain can be a very promising avenue, pain management, to improve our adherence of OUDs in the postpartum period. However, holistic approaches are needed given the complex biopsychosocial factors that intersect in OUD and pain, especially in the setting of birth hospitalization. These findings also emphasize the need for further research to elucidate actionable targets related to the pain in the immediate postpartum period for birthing people in OUD treatment in order to better advise physicians and caretakers about how to best manage the patients that have OUD who are going through the birthing process. And that is the end of our presentation. We would love to take any questions you guys may have.
Awesome job, Taylor and David. Thank you so much. So this data is from the perinatal buprenorphine database, which has generated a lot of papers for a lot of students. So I'm also thankful to the data and to the original group who got all that data chart abstracted. I have a question. I'll get things started and then we'll open it up. This is for both of you. So David, you might have something to add. Why do you think the Kaplan-Meier curve kind of, looks pretty obvious? Like, oh gosh, look, does seem to be a difference. But then when you did your proportional hazards model, even in the unadjusted model, right? The confidence interval crossed 1. So just curious if you had any thoughts of why the two kind of approaches that we took statistically might at least from a statistical significance perspective, we can all talk about the clinical significance separately, why it just seems to be a little different between the two.
Yeah, I think that's a great question. Somebody at the conference, the VA SMA conference, was really looking at that chart and being like, I don't understand why this is then not extrapolating to being significant because of how different it looks. David, you might have a better answer from a statistical perspective. But I don't know if it's because of the relatively small sample size of those that were prescribed opioids at discharge, because it was a group of about, I think, 26. We can go back and look at it. And if that has an impact on it once you run the Cox proportional hazard model.
Yeah, that's a great point, Taylor. So adding on to that, because the sample size is small, this increases the variability of the data points. So each data point has a lot more leverage. So if you have a lot of differences between data points, it can really increase the variance, and variance is proportional to the size of the confidence interval. So that might be why we're seeing such wide confidence intervals, and that's why we might see non-significant differences when we're doing Cox. But yeah, I think I think the statistical answer is probably very different from the clinical answer, but I think it just boils down to the variance.
Okay, great. Yeah, we're definitely gonna have to talk about that in the paper. But you're a very good point, David, that clinical and statistical significance, I think what you just said sounds really good. And I think shaping the discussion of the paper from that lens will be important and also just help the data make sense, and that it's not meant to change opioid prescribing guidelines, right? We're not trying to do that with a single institution study, but more just be like, hey, look, there looks like there's maybe something going on, and use it as data for future investigations.
I have a comment kind of about that and just a consideration for the paper. This ain't about that. I don't know if y'all can hear me.
Yes.
But I was just thinking about that. I thought that finding was really surprising, and thinking about how a lot of patients are concerned about being prescribed opioids, and there's a lot of stigma around these patients being prescribed opioids even when they need them. So I think just carefully wording that so it's not coming across as guidance, because I think it could be like one sentence picked out of a paper and used inappropriately. So just a kind of a word of caution from a clinical perspective about that.
Absolutely. I think that's a great point. And I've seen just from doing chart reviews how a lot of patients request not to be prescribed opioids at discharge that are pregnant. I think it would kind of be interesting to consider that as a factor, look into that. You know, how many have said they might not want it, and that how does that influence prescribing behavior?
Yeah, yeah. And did I might have missed it because I came kind of in and out with my little one. But did you all um capture why people were prescribed opioids? Like what it was for?
For that, no, it's just based on the chart reviews, abstractions that it simply asks the question, was the patient prescribed an opioid at discharge, yes or no? So we don't have the reasoning,
Gotcha.
but I agree that's an interesting avenue. I had somebody talk to us about the conference about looking at C-sections and vaginal deliveries and the difference there. As we had talked about, Dr. Martin, before, somebody asked that question, if we had looked at that. And I think incorporating those types of factors could be like another way to analyze this data and be able to understand the factors a little bit more in depth.
Yeah, yeah, absolutely. But really interesting. Good job, you guys.
Thank you.
Just curious, was it ever determined whether these prescriptions were filled or just prescribed?
That's a good question. I'm trying to think about what a chart reviewer would see, because I've done a couple of the postpartum ones, and it is just prescribed, not picked up for the opioid specifically, not the buprenorphine, which looks at the monitoring prescription system.
Yeah, you're correct, Taylor. We didn't check the PMP for anything except for buprenorphine. However, this was a hospital discharge, and a lot of these scripts are filled at the hospital pharmacy, but that is definitely a limitation we'll have to include in the paper, is that we didn't look at fills for these, and we didn't look at, of course, consumption. And there's so many papers talking about how you give people opioids and they don't use all of them, et cetera. So yeah, that's a good point. And then the other thing I'll say is that Taylor actually, at the very beginning of all of this, when she was designing her research questions, wanted to look at vaginal delivery and C-section and wanted to look at the opioid prescription. And I'm the one that said, let's just look at one because there's a lot of overlap, of course. So most of these patients got an opioid because they got a C-section. And that'll be in your, I don't remember that from your table one in your presentation, but I'm assuming that was the indication for most of it. But that, of course, there could be something else going on. But yeah, that will be, they're kind of two of the same a little bit in this situation. But when we were choosing which one to focus on to make it more relevant for future interventions, we did choose the opioid prescription. But yeah, that's right. Taylor did want to do both. And I'm going to give her props for that.
Yes, it's very interesting, but I do agree after looking at the data that I think there'd be like maybe two patients that, you know, it would be very, very small, taking that 26 or whatever it is and making that even smaller. So it'd be hard to kind of draw any conclusions from that.
Hi, this is Margie. Thank you so much for the presentation. It's always interesting to see the information, and I love that you all explained your data so well from a non-researcher. So thank you so much. I'm just curious with the protective factor. It sounds like that having a comorbid psychiatric condition has provided to people. Do we have any more information in that regard? I mean, are these patients, did they have closer follow-up, more follow-up? I mean, is there a possible reason or do we know?
That's a great question as well. I think if I were to take just a guess based on what I've seen, it would be because they are seen by healthcare professionals more commonly if they have that sort of diagnosis. And they are typically seen in the Motivate clinic and then on top of that by another provider. So it might just be that repetition of seeing a provider more often.
Thank you.
Yeah, just to add on to that, I think it would be just going back to what Taylor was saying about the biopsychosocial complexities of this issue. Having a psychiatric comorbid condition may have indirectly or like connected them to other behavioral and social interventions or resources or that kind of stuff, which could have indirectly helped them stay on buprenorphine. But it's definitely something that we were interested in looking at.
Good point. Yeah, just counseling and that extra support that could prop them up and help them maintain adherence to buprenorphine as well. Thank you.
Thank you.
This is Hannah, and just another comment, because that was part of the paper that used this data. The other thought is that if someone has a psychiatric condition, they may be more used to taking medications on a daily basis. So that can contribute to someone being more comfortable with buprenorphine or a different daily medication.
I think it's a great point.
Right.
Yeah, and Hannah, in your paper, I just pulled it up to try to remind myself, you looked at the receipt of medications and receipt of behavioral health in the postpartum period. And I know you had to like look at it at different time points in the postpartum period because it violated the proportional hazard thing. But you did find, if I remember correctly, that receipt of meds in the postpartum period was associated with a decreased hazard of discontinuing buprenorphine. So I think that's where some of that thought was coming from.
Yeah, for sure. And I also was thinking when I was looking at your curve for this study, I know it doesn't violate the proportional hazards, but I'm also curious if that's why you're not seeing that significant finding in the Cox regression, because it looks like the difference between the curves is bigger or smaller at different points in the postpartum period. So that also might be contributing, that it's significant only at particular parts when the gap is bigger.
Yeah, just to make a quick comment on the statistical aspect of this. So there's a few different statistical tests that you can use to compare Kaplan-Meier curves, but the Wilcoxon test is better for curves that are like the difference is concentrated at the start. So the fact that it sort of like tapers together at the end might have been another reason why we're seeing like these non-significant associations in the Cox. But yeah, when we did the log negative log test for proportionality, these curves were proportionally, especially at the start. So definitely things to consider for this data set.
I saw Gus's comment in the chat about formulation of buprenorphine. Thank you so much, Gus, for pointing that out. I actually have an answer to this question, ironically, because we've used this data set, like I said, for many many students' papers. And in this data set, Hannah's sister actually published a paper on the people who got Sublocade in the postpartum period, Carrie, and it was only like 15, I think, if I remember correctly. So it ended up being a case series. And so people who got Sublocade instead of sublingual bute, because this data is a little bit older. So it's 2017, 2020. And we didn't get, I don't remember exactly when we got Sublocade at Motivate, but it was, I think, in 2019, I think. I can't remember, but it was towards the end of the data for this. But yeah, that is definitely a hot topic these days, is the extended release buprenorphine, especially with Brixadi coming on the market and actually including pregnant people in their randomized controlled trials. So yes. This has been a great discussion. Does anyone else have any comments or questions, especially because Taylor and David are writing the paper right now? So this is very helpful.
It definitely is.
I'll just add one more thing, because I was pulling up the other paper that we kind of modeled some of these analyses after Davida Schiff's group at Mass Gen, and they have access to data for the state of Massachusetts. We haven't replicated this particular thing yet for Virginia yet for this question. But when they looked at bup or methadone discontinuation in the year postpartum in their cohort, they didn't look at opioid prescription at discharge. They look at opioid prescription in the 3 months before the birth hospitalization. And you know what's so funny is that their hazard ratio in their table, I looked up, is almost exactly the same as yours. And it's like it was point for the bup cohort only, it was 0.96 to 2.2. So in their so it's just kind of funny in their unadjusted model how this is it's different, right? This is different, right? This is usually this opioid prescription is going to be because someone had had a C-section, right? Something at the hospitalization versus an opioid prescription. At least clinically, I'm thinking an opioid prescription the 3 months before birth is going to be for something else, right? An acute pain episode or maybe a chronic pain situation, et cetera. So I feel like there's a little, not some overlap, but not a whole bunch on the indication. And it's interesting that your numbers are almost exactly the same as their paper found for this different variable.
Yeah, that's very interesting. I didn't really think about doing the prescription of opioids anytime during the pregnancy, but I think that would definitely be interesting.
Great. Well, if anyone else has any feedback for the team, please email us and let us know. Thank you, Taylor and David. That was great. Congratulations on getting this done. We're excited to see the next steps of the project. And yes, and thank you everyone for coming to the November lab meeting. And we will see everyone in 2024 in January for our next one. I hope everyone has a nice holiday.
Thank you.